with the talk, and I hope in this late evening session, I'm not, putting everybody to sleep with this talk on obstructive sleep apnea. We will be talking on obstructive sleep apnea, which goes hand in hand with obesity. Both of them are increasing at a very high rate and almost to pandemic proportions. Um, so my flow of contents for today's talk would be the definition of the disorder, what exactly is obstructive sleep apnea, followed by a little bit about the prevalence of both obesity as well as OSA. What kind of relationship do both of these disorders share with each other, whether it is unidirectional, bidirectional, or multifactorial, including starting from the etiology, the pathophysiology, and the treatment modalities. So, we will be talking about pathophysiology, mechanisms involved, when to suspect OSA in your clinics, and how to manage, diagnose, and treat them. So, what is exactly sleep apnea? Obstructive sleep apnea is basically one of the sleep related breathing disorders, which is characterized by obstructive apneas, which are actually defined by complete cessation of your breathing during nighttime sleep for a minimum of around 10 seconds, whereby the flow inside your pharynx, which you can see here in the diagram, your pharynx has just shrunken to a very small chink, leading to decrease in the airflow slowly to complete cessation of the breathing, causing nocturnal decrease in your saturations and intermittent hypoxia. So the cause obviously is repetitive collapse of your upper airway during your sleep, which may be caused due to your genetic factors, which can include the shape of your face and the composition of your pharyngeal muscles, as well as the inflammatory process, which we will be talking about in future slides. So the major risk factors to have OSA would be obesity and advanced age, and it has associations, as we all know, with obesity, insulin resistance, hypertension, arrhythmia, stroke, cardiovascular, and CAD health, as well as heart failure. So, coming on to the global prevalence of actually OSA, the total population of the world at the moment is approximately 7 billion, and 1/7, that is 1 billion of the population, does have the features of OSA. Now, OSA and OSAS, which is the obstructive sleep apnea syndrome, are two different entities, where OSA is defined by these apneas which we spoke about, and OSAS is, in addition, when you have extra daytime sleepiness, which many of you, I think, may be having at this late evening session at the moment coming back from your work. So the prevalence of OSA in USA is about 14.5% of the population. And when we come to obesity, about 2 billion of the world population is suffering from obesity, which is 1/3 of the total population of the world. So prevalence of OSA is twice as common in obese than in normal weight subjects. The countries with the highest prevalence would be China, obviously, because of the large population involved, the USA, the Brazil, and India comes fourth down in the list, Pakistan, Russia, Nigeria, Germany, France, and Japan. Now, men are 2 times more common at risk to suffer from OSA, but this would be premenopausal. Postmenopausal, even women are known to have increased prevalence of OSA. So the global burden of obesity is quite high, as well as the Indian burden of obesity is something around 135 million. Now, this is not a small figure. And as we saw earlier, the prevalence of obesity is increasing in children at pandemic proportions. And in one of the studies which we heard in today's talks, that about 35 to 40% of children do suffer from obesity in India. Now, there was a study by ICMR in 2015 whereby the prevalence rate of obesity varied from 11.8 to 31.3%. Now, there is a wide variation between these prevalence rates because the definitions which were used to know the obesity levels were different in different studies. Hence, there is so much of wide variation. So the central obesity was seen to be present in 16.9 to 36.3%, and it was the high socioeconomic status and urban population which were found to be having higher obesity prevalence. Um, the OSA prevalence in India, now this was a study which was done in 2016, is about 5.4%. Usually it is 4% in men, 2% in women, but it has gone up in a study which was conducted and known in India in 2016 to 5.4. Mind you, here we are taking the definition of OSA as apnea hypoapnea index of more than 15 per hour. In some of the studies, again, it is taken as more than 5 per hour. Now, there is a wide variation between different studies to calculate all these parameters. Hence, there is so much of variation which you are seeing. Also in 2016, the prevalence of sleep-related breathing disorders in children, mind you, these are 5 to 10 years small children which are there, the prevalence is much higher than adult people, which is amounting to about 9.6. Now, these are alarming proportions, and these children were known to have associated being overweight and obese, and they had metabolic syndrome like features 6 times more common than the other common children. Now, there are different mechanisms which increase the propensity of people with obesity to have OSA. Now, increased fat deposition around your upper airway tissues, along with the anatomical features which you might be having in addition to the genetic factors, which includes micronathia, having a smaller chin, having a heavy tongue. These are some of the genetic factors which increase your propensity to have OSA. In addition, the fat deposition around your neck and pharyngeal muscles lead to smaller lumen and increased collapsibility of your pharyngeal muscles during the sleep, especially in supine position. So truncal obesity causes reduced chest wall compliance and decreased functional residual capacity, leading to increased oxygen demand and hence the problem of OSA. So leptin receptor polymorphisms are also involved, which we will be talking a little bit in the pathophysiology. Obesity as a consequence of OSA causes reduced exercise capacity and reduced motivation to have a healthy lifestyle, which further leads to depression and hence a cyclic, propensity to have a very unhealthy lifestyle. Eating more, the behavioral changes which happen with depression. You eat more, try to sleep more because you're less active during the day, and spend more time in the bed. The pathophysiology of the obesity as well as OSA is quite overlapping in the form of the metabolic milieu and inflammation, which is caused in both and leads to the heightened systemic inflammatory state, which can be manifested in the form of increased cytokines, which are the IL-6, IL-1, IL-18, and tumor necrosis factor. There can be increased levels of amyloid A as well as CRP levels, but the CRP has not been corroborated in many studies. Now you can see in this slide the adipocytes which are altered in patients with obesity and OSA. They lead to a lot of production of factors which can be in the form of resistin, adiponectin, angiotensinogen, leptin, osteopontin, and various other factors. Now, these are mostly stimulants for the macrophages, which increase your inflammation process and hence lead to endothelial activation, and angiotensin activation, and vasoconstriction, as well as sympathetic overactivity. Adiponectin is one of the factors which is actually anti-inflammatory and causes nitric oxide release, which we all know is a vasodilator, and it increases your insulin sensitization. Now, the consequence of all this is that there is an inflammatory milieu which is self-sustaining in the body, both in obesity as well as OSA, hence leading on to mechanisms which leads to increased cardiovascular morbidity and mortality, as well as the other factors which are present in these patients. Now, increased leptin may cause abnormal breathing patterns both in OSA and obesity hypoventilation syndrome. Low adiponectin, as we spoke about, increased IL-6, TNF-alpha, and high ghrelin. Now, ghrelin is a hormone which is secreted by the greater curvature in the stomach present in the fundus, which is actually targeted in surgeries involving bariatric surgery. So hence there is a self-perpetuating process in the body, both in obesity as well as sleep apnea, and all these are interrelated, causing in effect and a consequence related situation where there is perpetuation of these cycles happening in the body, leading to sleep deprivation, further leading to lifestyle changes, sleep and eating disorders, depression, anxiety, and then causing increased visceral fat, CRP levels, causing increased leptin, insulin resistance, and hence leading on to all the cardiovascular risk enhancement mechanisms. Some of the patients are also known to have chronic kidney dysfunction, in addition to increased and heightened propensity to have a stroke. Now, sitting back in your clinic, when do you suspect that a patient needs a sleep study and the OSA needs to be catered to? Now, there are different strata of people which would come to you with symptoms, and they would have checked everything in the internet would tell you that I think I have developed obstructive sleep apnea. Mostly their partners, noting down that their partners do have some problems during the habitual snoring happening with the cessation of breathing, in the form that there is complete cessation of these snoring, and then the patient gets up suddenly in the middle of the night to have a gasping breathing. Mostly we do get patients like that where the partner suspects the person to have these kind of problems. So extra daytime sleepiness is something which can cause problems in your daily routine, being unfresh and not feeling fresh early morning, and getting up very tired, having chronic fatigue, and also having problems while driving, and problems having concentrating. So, unrefreshing sleep, fatigue, recent mood disturbances also should be considered as one of the presenting forms of features of OSA. Obviously, you have to suspect your patients who are morbidly obese, where the BMI is more than 40, and in case of those having BMI more than 35 with certain comorbidities like diabetes and OSA per se. Now, OSA is about 70% more common in morbidly obese patients, and these are the patients who should be taken into account when you are referring them for their sleep studies. Uncontrolled hypertension is one of the modalities where you will be confused that why my patient's blood pressure is not getting controlled despite me giving them three or more than three drugs to control their hypertension. I have had many patients coming with this complaint that the hypertension was earlier controlled, now my hypertension is not controlled, especially after a certain level of weight gain during the lockdown period. Now, congestive cardiac failure per se can have increased propensity to have obstructive sleep apnea. These patients may or may not be having any kind of symptoms, and ideally, every patient who's having CHF should undergo sleep study, because they also have something called chain stroke breathing during the night, which can actually increase their risk to get a sudden cardiac death during their sleep. So 11 to 53% of the patients who were having congestive cardiac failure were found to have associated OSA in the sleep heart study, which is one of the largest studies which has happened for sleep previously. So patients planned for bariatric surgery, these are some of the patients which will be having obesity associated with them, and especially they should be sent in for a polysomnography, because these are the patients which can have perioperative problems after their bariatric surgeries due to their OSA per se, because they are given certain anesthetic agents during the operation. So they might have certain problems related to waking up post anesthesia and getting weaned off from the ventilator. So they do have problems. So do refer them for polysomnography. So excessive daytime sleepiness is something which you can assess by a Perth sleepiness score. It is a very simple scoring, which you can keep a chart with yourself in your clinic, and it involves asking questions like, do you have a chance to doze off in situations which are the following, which can be sitting and reading, watching TV, sitting inactive, being a passenger, lying down to rest in the afternoon. And the scoring is from 0, 1, 2, and 3, where 0 means no chance and 3 means most chance of going on to doze in these kind of situations. So less than 11 is normal, and more than 11 out of the 24 total would be significant. Management obviously involves diagnosis, which can be in the form of questionnaires and prediction algorithms, which is something like Stop Bank questionnaire, which is again a smaller questionnaire of 10 questions which you can ask these patients and keep a copy of in your clinic. But usually it has been seen that questionnaires and prediction algorithms, they do not predict a person to be corroborating to having OSA. So they should be given the option of undergoing sleep study, which is called the split night polysomnography, which happens half of the night to study their EEG rhythms, their electromyograms, and the other electrodes which are fixed around the chest and abdomen to know the pattern of their breathing, as well as the thermistors which are put in inside the nose to know the flow of air which is happening around the nose. So there are certain settings where you can perform these studies in and around their home, which is kind of a limited polysomnography, which you can where you can skip certain of your electrodes and not put certain of them, because at home it's not possible to cover everything and put every kind of electrode and monitor them. They're also monitored for their SpO2, which is the oxygen saturation. In certain cases, just to screen these patients, we can also put the SpO2 monitor and watch them bedside during their sleep if they are having certain kind of witnessed apneas and desaturations associated with them, leading on to arousals and microarousals, which you can see by your naked eye, and hence give them a therapeutic trial in resource limited setting. But obviously, these are not the gold standards to make a diagnosis of sleep study and give them a complete prescription, including what amount of pressures they need to be having, and also exclude certain conditions which can be in the form of central sleep apnea, and as well as mixed disorders, which can happen in patients, especially with heart failure. So CPAP therapy, what is CPAP therapy? CPAP therapy is something which is called continuous positive airway pressure therapy, whereby the mechanism by which your upper airway is getting collapsed during sleep, that is helped by the positive airway pressure in the form of keeping your airway patent during sleep when you sleep, especially in your supine position, and the tongue falls back to cause the collapsibility of your upper way. It is in fact the tenting of the pressure which goes inside through the CPAP, which keeps it open, and hence leads to reduced daytime sleepiness, which has been corroborated in various studies. It may or may not contribute to weight loss. Now, there was a study which was conducted in recently in 2018. The number is not much, but it was seen that actually patients who were given CPAP therapy, they had a weight gain of about 5 kgs post their CPAP therapy. It may be that they actually slept well and skipped their exercises and had the unhealthy lifestyles, and hence they put on weight. But mostly it does contribute to weight loss, considering the bidirectional relationship with OSA and obesity, which these actually have. So people become more active during the day, They are more receptive, and they contribute and participate in their exercise programs and rehabilitation programs in a better way. Their mood actually changes, and they may be more amenable to behavioral therapy, which is known to be very helpful in weight loss. They do have better blood pressure control. uh, so they may have reduced total cholesterol levels, increase in their HDL levels, better glycemic control, and insulin sensitivity, in, which further leads on to improved endothelial function and reduction in the inflammatory markers. Now, these are something which have been shown to have different effect in different studies. Some of the studies have seen improvement in all these levels, but there are a large number of data where they have seen CPAP therapy has actually not helped in terms of reduction of inflammatory markers, especially, and in terms of insulin sensitivity. Now, there is not any kind of robust data available for patients with the OSA and insulin sensitivity because of the different definitions which are involved to define OSA and obesity. Um, One of the factors which may be hindering a lot of data in terms of OSA and obesity studies with CPAP therapy would be the fact that actually polysomnography is a very expensive test, and it is not covered by the insurances in most of the states throughout the world. So patient, they don't want to spend onto their polysomnography pre and post therapy of start of their problems. So this is one of the major limiting factors where we are not able to study the effect on the inflammatory markers. Obviously, they do have improved quality of life. They are able to better engage in their work as well as have a work-life balance. There are studies to see reduction in the visceral fat, which happens with CPAP therapy, but whether that leads to decrease in their cardiovascular risk health is again questionable, and whether it leads to decrease in the mortality is again questionable. Now, this is the study of CPAP for the prevention of cardiovascular events in obstructive sleep apnea, which happened in 2016. This is one of the largest data of CPAP in OSA. So the study was a randomized controlled trial, and it was done on about 2,700 eligible adults of the age group of 45 to 75 years of age with moderate to severe OSA. Now, moderate to severe OSA means having an apnea hypoapnea index of 15 or more than 15, something, the apnea hypoapnea index anywhere between 5 to 15 is considered as mild OSA. So the primary endpoint which they studied was death from cardiovascular or CAD event, or hospitalization for unstable angina, heart failure, or transient ischemic attack. They did not see any prevention in the events related to cardiovascular health in patients with moderate to severe obstructive sleep apnea with the use of CPAP plus usual care, as compared to people who were given only the usual care. So long-term cardiovascular event prevention was not seen to be happening with the use of CPAP therapy. So what is the implication of this study? This study is an indication that once a patient comes to, especially the pulmonologist for the sleep study, they should not be left high and dry only with the use of CPAP. They should be given additional therapies in the form of weight loss regimes, as well as they should be referred to take care of their metabolic health to an endocrinologist, so that they are given a comprehensive plan to take care of the inflammation which is actually happening in the body and which is not getting settled with the use of CPAP. So weight loss is one thing which has actually helped in long term and sustained therapy in case of obstructive sleep apnea. But the weight loss of 10 to 15% is not actually sufficient to prevent or decrease the number of AHI in these people. So this was a very long study where the patients were followed up for 14 years. The dietary weight loss, which led to overall median success of only 15%. Only with the diet was not very robust. So you can see that the estimated percentage change in AHI was somewhere between 48 when the weight changed about 20%. Now, the heart health study, which we spoke about earlier, was seen to be contributing to the AHI index change of about 26 when the weight loss was about 10% of your body weight. So, Sleep Ahead trial, which is a randomized controlled trial, saw a decrease in the weight from 10.8 kg in the intensive lifestyle management group compared to only zero point 0.6 in the control group, and 13.6 percent of the people had remission of their OSA versus 3.5 in the control group at 1 year. Now, you'll see a lot of studies where they have seen, especially in the weight loss regimes, both dietary controlled as well as the bariatric surgery, where they have seen improvement in the apnea hypopnea index. And in addition, some of the people might have gone into remission in terms of their OSA. But after 1 year, when these patients were followed up, 50% actually had return of their symptoms and they had to again use CPAP therapy. Now, this was a study which is multidisciplinary weight loss intervention in youth with obesity. This is a randomized controlled this is a uh, you know 10 trials were included in the studies, and 90% of studies indicated decreased prevalence of OSA post intervention. OSA was normalized in about 46 to 80% of the children, and there was a significant reduction in AHI and oxygen desaturation index. So this is a meta-analysis actually, where they have seen in children actually it does help if you have multimodal and multidisciplinary team involvement in terms of weight loss. So if small children are coming to you with the problem of OSA, they should be subjected to robust weight loss mechanisms. I'm
Okay,
not going
Vinny, we
to
are
go
running
into
a bit late, so if we could.
Yeah, I'm not going to go into the details of the medical therapy. Liraglutide, Orlistat, both of these are available in India. The other two are not as yet available. But you can see that the weight loss is not very robust. Bariatric surgery, which is very good in terms of reduction in all-cause mortality and CV mortality, is the most effective tool for significant and sustainable weight loss. And Roux-en-Y gastric is associated with the reduction of 33 events per hour at the end of 1 year. But mind you, in 50% of the subjects, the symptoms can return, and certain people are actually able to discontinue their CPAP therapy at the end of bariatric surgery. There are three kinds of bariatric surgery, which we are not going to go into the details, but the most common, which is performed at the moment, is lap sleeve gastrectomy as Roux-en-Y. And these are some of the studies where they saw change in the apnea hypopnea index and BMI changes. So take home would be suspect early for a better quality of life, treat early for the prevention of CV complications, don't take them per se standalone OSA cases. Please go down deep into the metabolic milieu and take care of the weight loss regimes, which is a very good therapy to consider in case of metabolic derangements and metabolic syndrome. Engage in weight loss regime programs. CPAP therapy, as compared to surgical correction in moderate to severe cases of OSA, should be preferred, and bariatric surgery can be considered early wherever it is indicated. And especially, please do not forget to counsel your patient in the right manner. They should be told that what exactly is important. It's not only their extra daytime sleepiness which we are targeting at, but we should actually take care of the cardiovascular health and increase mortality, which is associated with the increased inflammatory milieu which is present in these patients. And hence, they should also be told that they might go on to the PAP therapy again after they have their surgery for morbid obesity.